Coagulation, Disorders of Primary Hemostasis, Chapter 25. How and why? Abnormalities that clinically result in bleeding due to defects in formation of platelet plug, quantitative or qualitative, defects of the blood vessel wall, inherited or acquired. Clinical manifestations, typically limited to skin and mucosal bleeding. Laboratory tests to assess disorders of primary hemostasis. Platelet count, peripheral blood smear, IV bleeding time or PFA 100, von Willebrand studies. Factor 8C, von Willebrand factor antigen, von Willebrand factor activity, platelet antibody testing, flow cytometry, platelet glycoprotein analysis, platelet-associated immunoglobulin G, platelet aggregation studies, Lumi aggregometry, CR release, and bone marrow aspiration and biopsy. Automated platelet count is an important initial test. Acquired quantitative platelet disorders are most common primary hemostasis issue, thrombocytopenia. The peripheral blood smear is a visual inspection of the morphology and can show if there are large or dysplastic platelets, satellitism, or clumping, which are often seen in these disorders. The bleeding time is screening for platelet and vascular disorders. Abnormal bleeding times can occur with qualitative disorders, quantitative disorders, certain vascular defects, and von Willebrand's disease. Von Willebrand studies. Von Willebrand factor mimics platelet disorder bleeding and must be ruled out. Qualitative disorders. Thrombocytopenia. Platelet count of less than the lower limit of normal, which is 150 to 400. Clinical signs 100 to 50. Overt spontaneous hemorrhage less than 20. Life-threatening hemorrhage less than 10,000. 3 mechanisms: deficient platelet production, abnormal platelet distribution, increased destruction. Deficient platelet production. Disorders produce megakaryocytic hyperplasia, erythroid and granulocytic hypoplasia, pancytopenia. Spontaneous through aplastic anemia. Result of injury, radiation or chemotherapy. Replacement of marrow hematopoietic tissue, myelofibrosis, leukemia, or lymphoma. Ineffective thrombopoiesis. Megaloblastic anemias, which include vitamin B12 deficiency, folic acid deficiency, and impaired DNA synthesis. Myelodysplastic syndromes. Alcohol, which has a toxic effect on the marrow and can cause vitamin B12 and folate deficiency. Congenital disorders. Alport syndrome, which causes giant platelets, thrombocytopenia, deafness, and nephritis. Chiari-Higashi syndrome, which causes partial oculocutaneous albinism, increased susceptibility to pyogenic infections, storage pool defect of dense granules. Hermansky-Pudlak syndrome, which causes platelet deficiency of non-metabolic ADP, oculocutaneous albinism, May-Hegland anomaly, which can cause thrombocytopenia, giant platelets, and Dolly bodies. TAR syndrome, which causes multiple skeletal and cardiac abnormalities, storage pool defect. Wiskott-Aldrich syndrome, which is a disorder of dense granules, causing recurrent pyogenic infections, eczema, and thrombocytopenia. Abnormal distribution of platelets. Splenomegaly. The spleen pools 1/3 of platelets. The spleen enlarges and more platelets are stored. Liver cirrhosis. Hematologic malignancies and portal vein thrombosis. Increased destruction of platelets. Primary immune-mediated mechanism. Idiopathic thrombocytopenic purpura, the most common disorder. Autoantibody to the patient's platelets, typically a diagnosis of exclusion, adults and children. Childhood ITP, acute 1 to 2 week duration, bruising and petechiae, platelet count of less than 20, bone marrow to rule out leukemia. IgG and corticosteroids decrease the time period. Splenectomy is avoided. Adult ITP, 20 to 50 years old. Platelet count of less than 30. Mucosal bleeding. Menorrhagia. Epistaxis. Easy bruising and petechiae. The clinical findings. Bone marrow shows increased or normal numbers of megakaryocytes. The platelet lifespan is shortened. Platelets are morphologically large. Increased destruction of antibody-coated platelets in the spleen. Bleeding time may be prolonged. Other platelet diagnosis must be ruled out. The treatment is splenectomy, which is long-term treatment of choice. Corticosteroids, they respond well initially and 25% sustain, and IgG. Post-transfusion purpura, sudden onset approximately 1 week after transfusion. Alloantibody against platelet antigen P1A1 or HPA-1A. 97% of the population has HPA-1A. The 3% that do not are at risk. Platelet transfusions are not effective. Plasmapheresis without exchange and intravenous IgG infusions. Testing has been developed. Use of ELISA, Western blot, radioimmunoassay, platelet suspension immunofluorescence, and immunoprecipitation of radio-labeled glycoprotein 3A. Isoimmune neonatal thrombocytopenia. Maternal alloantibodies to HPA-1A antigen. Uncommon. Within hours, scattered petechiae and purpuric hemorrhages. Less than 30 per platelet count. Intracranial hemorrhage is primary cause of mortality. Corticoid steroids or intravenous IgG. Keep platelet counts at safe levels. C-section. Try to prevent intracranial hemorrhage. Drug-induced thrombocytopenia. Quinine, quinidine, salicylates, thiazidides, and sulfadrugs. Elicit an antibody response when complexed with larger molecule. Cellular binding or adsorption of the antibody-drug complex to the platelet membrane. Splenic sequestration. Purpura are 7 days post-initial. 3 to 5 days re-exposure. Platelet count returns to normal upon once drug has cleared. Disseminate intravascular coagulation, or DIC. Acute DIC is from sepsis, obstetric emergency, severe trauma, and bleeding. Chronic DIC is caused by cancer or thrombosis. Thrombocytopenia happens in acute DIC, normal to elevated in chronic. Accelerated platelet destruction in combination with coagulation factor consumption. Hemolytic uremic syndrome. Hemolytic anemia, which is characterized by schistocytes and target cells. Thrombocytopenia, renal failure, higher mortality rate in children. Thrombocytopenic purpura, severe neurologic problems, systemic thrombi, adults. ADAM TS13 protease levels are severely depressed. Quantitative platelet disorders, thrombocytosis. Thrombocytosis is a platelet count above the normal range. Reactive process, primary myeloproliferative disorder, or MPD. Primary thrombocytosis, myeloproliferative disorders, or blood cancers in which the bone marrow makes too many abnormal red blood cells, white blood cells, or platelets, which accumulate in the blood. The type of myeloproliferative disorder is based on whether too many red blood cells, white blood cells, or platelets are being made. Essential thrombocythemia, or ET, is a condition in which the bone marrow produces too many platelets. Chronic myelogenous leukemia is a cancer that starts in the bone marrow. Polycythemia vera is a bone marrow disease that leads to an abnormal increase in the number of blood cells. Primary myelofibrosis is a disorder of the bone marrow in which the marrow is replaced by fibrous scar tissue. Many people with ET have a mutation of a gene, JAK2, CALR, or MPL. Reactive thrombocytosis. Abnormally high platelet count in the absence of chronic myeloproliferative disease secondary to an infection, inflammation, and hemorrhage. Iron deficiency anemia. Qualitative platelet disorders. Congenital disorders. Rare, classified on platelet function or response that is abnormal. Platelet surface membrane defects. Platelet release or secretion defects. Platelet anticoagulant activity defects. Defects associated with abnormal platelet coagulation protein interactions. Platelet membrane defects. Glanzmann's thrombasthenia. Bernard-Soulier syndrome. Platelet release or secretion defects. Storage pool deficiency granule defects. Primary secretion defects or enzymatic pathway defects. Platelet coagulation defects and von Willebrand disease. Platelet membrane defects. Glanzmann's thrombasthenia. Platelet count is normal. Platelet morphology is normal. Bleeding time is prolonged. Platelet aggregation. ADP is abnormal. Thrombin is abnormal. Collagen is abnormal. Epinephrine is abnormal. And ristocetin is normal. Clot retraction is abnormal. Platelet glycoprotein defect, GP2B3A. Bernard-Soulier syndrome. The platelet count is decreased. The platelet morphology shows giant platelets. The bleeding time is prolonged. The platelet aggregation, ADP is normal. Thrombin is abnormal. Collagen and epinephrine are normal, and ristocetin is abnormal. Clot retraction is normal. Platelet glycoprotein defect, GP1B9. Glanzmann's treatment. Good dental care. Avoidance of antiplatelet drugs. Platelet transfusion to replace dysfunctional platelets when bleeding episodes occur. Alloantibodies to GP2B3A. Anti-HLA. Bernard-Soulier treatment. Red blood cell transfusion with antifibrinolytic agents. Estrogen therapy. Occasional platelet transfusion. Alloimmunization to GP1B. Platelet release or secretion defects. Platelet glycoprotein receptors transmit signals intracellularly to release platelet granule substances. Shape change or contraction. Expression through the OCS. Adhesion and aggregation. Avoidance of platelet granules. Defective enzymatic pathways. Storage pool deficiencies or granule defects. Classified. Granule proteins. Decreased platelet dense granules are most common. Alpha and dense granules decrease. Morphologic. Gray platelet syndrome causes a decrease in alpha granules, give a granular appearance of platelets. Quebec platelet disorder causes a decreased activity of PF3 and defects in platelet aggregation. Hermansky-Pudlak syndrome causes dense granule storage pool deficiency. Chereakagashi syndrome causes dense granule storage pool deficiency. Wiskott-Aldrich syndrome causes associated platelet storage pool deficiency. TAR syndrome causes associated platelet storage pool deficiency. Laboratory features storage pool deficiency. Bleeding time is prolonged to normal. Plasma coagulation screening and factor assays are normal. Platelet counts are normal. Morphology is normal with the exception of gray platelet syndrome and Chereakagashi syndrome. Dense granule deficiencies seem more severe. Primary secretion defects, enzymatic pathways. No abnormalities of platelet granules. Deficiencies of enzymes. Cyclooxygenase deficiency. Thromboxane synthetase deficiency. Von Willebrand disease. Inherited deficiency of von Willebrand factor. Von Willebrand factor forms a complex with factor VIII, protects factor VIII molecule from proteolytic degradation and increases concentration at the site of tissue's injury. Absence or dysfunction results in decreased factor VIII. Platelets are normal, exhibit abnormal adhesion. Abnormal secondary hemostasis. Classification of von Willebrand disease. Type 1 autosomal dominant, 70%. Qualitative decrease in normal von Willebrand factor and mild bleeding. Type 2 variable inheritance. Most of the remaining cases. Qualitative abnormality in the structure of von Willebrand factor. Type 3 rare autosomal recessive. Absent levels of von Willebrand factor multimers and a secure bleeding diathesis. Testing. Bleeding time, factor VIII activity, platelet count, and plasma von Willebrand factor antigen, which is quantitative. Acquired qualitative platelet disorder. Renal disease or uremia, liver disease, paraproteinemia, myeloproliferative disorders, acquired von Willebrand disease, cardiopulmonary bypass, acquired storage pool deficiencies, and drug therapy. Vascular disorders. Primary purpura, bruising that is not associated with any specific disease. Secondary purpura, results from another disease process. Glanzmann's thrombasthenia shows prolonged bleeding time, absent platelet aggregation in response to ADP, thrombin, collagen, and epinephrine, and normal platelet aggregation to ristocetin and bovine von Willebrand factor. Thrombocytopenia, fever, renal disease, microangiopathic hemolytic anemia, and neurologic complications are hallmark characteristics of thrombotic thrombocytopenia purpura. Myeloproliferative syndromes are classically associated with thrombocytosis.